Thank you all today for joining us. We will be having our first conversation piece on social determinants of health. Again, we met. I haven't had a chance to be in the breakout room with everyone, but again, my name is Keith Hughes. I am the Senior Public Health Educator for the City of Detroit Health Department. And
And I am Lloyd Allen. I'm an assistant professor in the School of Social Work. And as Keith stated, we're going to talk a little bit about strengthening community, academic relationships, and we're talking specifically about social determinants of health. My portion of it is going to be fairly quick, and it's going to talk about some of the issues that GLBT individuals face, specifically when accessing adequate healthcare. Next slide. Next slide. So one of the things that we have to think about specifically when we think about determinants of health is that 33% of gay and sexual minority youth report being bullied, and these are individuals who are in schools. But overall in the US, there's roughly, in 2019, there were roughly 1429 victims that had some kind of violence towards them, and primarily it was due to sexual orientation. So 61.8% were anti-gay male bias, 25% were anti-lesbian, gay, bisexual, transgender, mixed group bias, 10% were anti-lesbian, and 1.9 and 1.3 were roughly anti-bisexual bias and anti-heterosexual bias. And so with anti-heterosexual bias, part of that is looking at individuals who are gender nonconforming. So when you think about gender identity, if you can go back, next slide, sorry. Of the 227 victims, 175 were victims of anti-trans bias and 52 were anti-gender nonconforming bias. Again, part of it is just looking at people who didn't like someone because of the fact that they were transgender, and then people who were gender nonconforming. Next slide. So one of the things that I did was I went and looked at the state of Michigan, particularly what's happening statewide. And so in 2021, there were 610 incidents associated with a hate crime. And so that's overall race, gender, religion, disability. And of that, an incident is one or more offenses committed by a person acting together at the same time and place. And of that number, 76 were on sexual orientation and 19 were on anti-gender. Next slide. And so this slide shows that individuals between the ages 10 and 30 have the highest had a hate crime against them. And so part of it, the majority were anti-gay bias. And this is data from across the state of Michigan, not just in Detroit. Detroit had a very lower number. So Detroit had about, in 2021 alone, had about 24. But in the state of Michigan, we had 95. And the majority coming were anti-gay bias. Next slide, please. So when we're thinking about, so when we're thinking about how do we provide treatment services, recognizing that policing GLBT bodies create a critical role in how, when, and where they receive treatment. So unfortunately, there's a lack of visibility for programs. Most programs are created for youth and young adults who are between the ages of 14 and 29 and are focused heavily on HIV prevention. So that includes, so what that does is that excludes individuals who are older than the age of 30, individuals who are not HIV positive. So if you're HIV negative, there are a lot fewer resources for you. It ignores the unique needs of older and aging adults, bisexuals, and transgender individuals specifically, and creates an assumption that bisexual individuals are gay. Next slide. When we're thinking about it, we also think about stigma, right? So a bisexual person is not interested in gay counseling. So if a bisexual person comes in for counseling, they want to talk about both aspects, being bisexual, what does that mean? What does that look like? Rather than the catch-all phrase of, well, if you're bisexual, you're gay. There's also this notion of bi erasure, where if someone says that they're bisexual, people will automatically assume that, hey, you're just gay or you're confused. And as counselors, we have to be very conscientious of what that means. We also have overly simplistic and inclusive catch-all terms to address the lived experiences of GLBT. Individuals who are not defined as queer or trans, their unique needs may be different than someone who says, look, I am gay, I am lesbian, I'm bisexual or trans. And we need to move away from prevention plans or programs that use a cookie cutter process. And we also have to think about when we're looking at lesbians and bisexuals, we have to take a look at what are some of the underlying and comorbid issues. What we know is that lesbians specifically have higher rates of substance use, drug smoking frequency, and drug use. And when they go into therapy, and part of that could be just, society, if you're a lesbian and you have a child, then you're automatically treated as straight, even if you say you're a lesbian. And so they have to navigate that line of like, well, I'm a lesbian, how do I get access to equitable services? Or being a lesbian, you're seen as, you have two strikes against you, being the sexual minority and being a gender minority, right? Sexual minority, lesbian, gender minority, being a woman. So services are not necessarily catered to you in that context. Next slide. Recognizing that gay men have sex while being chemically induced, a process known as chemsex, as a result of internalized stigma associated with sexual orientation. So when they are coming in for treatment and they're talking about drug use, we have to think about why would they be on drugs if they are interested in, if they're gay, why are they having sex while they're high? Or why are they having sex while they're drunk? Why are they more likely to do certain things while they're on drugs and sexuality? We also think about mental health, and service providers should be open and willing to address sexual behaviors using the same level of transparency that they use with their heterosexual clients. So they have to be open to addressing an anal intercourse. If you're a therapist coming in, if a client is coming into you, you have to be willing to talk about what does anal intercourse look like? What does dildo use or dildo play look like? Willing to discuss sex between two men, two women, sex with trans individuals, the same way they talk about it with sex with their heterosexual counterpart. Next slide. And so lastly, I want you to think about health-related research that focus heavily on aggregated data. Much of what we know is an aggregated data resulting in standardized individual treatments. So that's it. I am turning it over to Keith.
Yes, so I want to get in more into the LGBTQ plus health equity, addressing the disparities to better health outcomes within LGBT individuals. Next slide. So, what are social determinants of health? These are the non-medical factors that influence health outcomes. They also are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. So, these are the constraints of what actually helps individuals maintain better health outcomes. So, I know one of the pieces that I always talk about is cultural upbringing. What does that look like in the communities that we grow? What influences may be involved with not only social determinants of health, but just your own perception on life in general, and how that may shape or mold your way of engaging or even having conversation about your own sexual health. Next slide. So currently, approximately, there are 373,000 LGBT individuals who reside in the state of Michigan. We all know that LGBTQ plus individuals experience the highest incidence related to discrimination and stigma. Uh, Over the years, I feel like we have the same conversation whenever we meet around housing, employment, and also healthcare continuing to cripple the equity of LGBT individuals. I think that's one of the main pieces that Mr. Allen was discussing in his slides around stigma and what that looks like with individuals even being willing to engage in those services in services that are being provided that may not be culturally um, aware of the communities that they are being that they are currently serving. So next slide. What is health equity? And I think this is one of the pieces that I've had conversation with in the past around that difference between health equity and health equality. So health equity is the absence of unfair, avoidable, or remedial differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. or by other dimensions of inequity, sex, gender, ethnicity, disability, and also sexual orientation. So these constraints could make or break an individual's um, equitable health outcomes. Next slide. So, what are some barriers LGBT individuals face to achieving health equity? Again, we have these conversations all the time around education, employment, gender affirmation. That's one of the biggest pieces. HIV and sexually transmitted infections, mental health, also internal and external stigma and what that looks like. To individual and also substance use. So these have been one of the main conversations regarding these pieces around health and equities, particularly around LGBTQ plus individuals. Next slide. So comorbidities in LGBT individuals. HIV is the biggest health concern affecting men who have sex with men. We all know that it shows up in data across the country, especially particularly here in Michigan, knowing that the city of Detroit carries the highest burden related to HIV. Also, LGBT individuals are impacted by discrimination and stigma. Transgender women are impacted higher from out of all of those groups as it relates to stigma. Uh, LGBT individuals also have a high percentage around mental health disorder and also substance use. One of the other pieces is the latency to cancer diagnosis among LGBT individuals due to awareness and access to screening, cancer prevention, and also high quality care. And I think that's one of the conversations that I love to have with providers who are providing HIV care services to those individuals around screening and also bringing more awareness and advocacy to those individuals that are taking antiretroviral treatment. And also the pay gap among LGBT individuals are still experiencing they're still experiencing challenges around adequate income and particularly with transgender individuals. And I know this is one of the pieces I question around whether they're putting this or housing, but for me, employment is one of the biggest keys to maintaining health equity, whether it's mental health services, medical services, housing, food equity, and things like that. So if you don't have a base income, then how are you able to sustain medical and non-medical services to maintain better health outcomes? Next slide. So how can we take action to improve LGBTQ health equity, improving institutional and structural barriers around cultural humility, gender affirmation, and also policies that may be the biggest burden to acknowledging some of these constraints and also building better resolution to meeting the needs of LGBTQ individuals. Also, cost-effective housing, short-term housing, financial literacy, and also rental assistance programming. A lot of times, a lot of these services are available in the community, but the community aren't necessarily aware, especially individuals living with HIV. How do they receive HOPWA funding or rental assistance? Where can they go, especially if those services aren't necessarily promoted or talked about within their own networks? So getting the word out there. Also providing safe spaces for the community, not only just having a facility that is a safe space, but also making sure the community is aware and it's within the community that needs that service, and also having staff that provide that safe space, particularly individuals from that community, and also just the accessibility around transportation, the community visibility, and also buy-in. Also, another way of accessibility that I didn't put down here is also the visibility around telehealth and making that more accessible for individuals who may have barriers around transportation or just the anxiety and stress around sitting in clinical spaces and being around individuals that they may not feel comfortable with having conversations with around their own sexual health. Next slide. So that is the end of my slide. My contact information is on here. And I know that we're going to break out into some breakout rooms to have better dialogue around these topics, to build some action around these conversation, things that we can take away from this conversation to kind of build a better build workforce, and also um, some action around some of the conversation we're having now. So that's it for me. I don't know if this is the piece where we'll go into either the breakout station or questions will be posed.